So I'll be showing you some of the instruments that ASICO helps me with. The first instrument that together we came up with for holding the lens, it is made to handle the lens optic of various materials. So it can hold not just hydrophobic acrylic, it can grasp hydrophilic acrylic, it can hold PMMA, although you have to be careful that you don't squeeze the forceps too hard, that the optic can actually pee-pod out. It can hold silicon with some difficulty. Okay? So it comes as a 21 gauge instrument, but also available in the 23 gauge instrument. This is one of the newer forceps that is slightly different in that it is angled, and this is specially meant for holding optics that are dangling in the vitreous cavity in a vertical position. So this is in a 23 gauge. And then there's also a suture retrieving hook, which you see here, that is specifically designed to hook onto sutures in the anterior chamber when performing the Sipser sliding knot. So although you can use other hooks like the Coughlin hook, that instrument is actually, the hook is vertically placed, unlike this is horizontally placed. So when you hook the suture, you do not need to actually turn the instrument, which means that your elbow has to come up before you can hook onto the instrument, to the suture. This is actually intended for you to hook onto the suture either from the left or from the right, depending on where your suture is placed and which is most convenient. So let's look at this case now. These will all be videos to follow. So I'm going to first show you iris fixation, which I think really is the simplest technique, the least complicated, and the quickest to do when you have inadequate capsular support. It can be done within half an hour. So this is how I'm going to show you the use of a 23 gauge straight and the angled forceps. Okay, so the lens is clearly visible. I'm just using a forceps to hold on to the haptic. That's the easiest thing to grasp in this case. So you see the lens holding forceps there. You can hold the haptic, you can hold the optic. This is the angled one. That's good for something that's vertically aligned. It's very slim. It goes through a less than 1 mm incision. So before you move this lens, you really don't want to snare any vitreous. So staining vitreous with triamcinolone acetonide is very important for you to visualize it. And then with the 23 gauge retractor, I then proceed to remove the vitreous without actually pulling on the lens until it is completely freed. Especially the haptics, you need to be very sure that these are completely devoid of vitreous before you manipulate them to the anterior chamber. So you can see sometimes they can prolapse from the side ports, which are intended to be rather snug so that you don't lose vitreous, okay, and you maintain the anterior chamber. And you can see this lens is actually a very old lens. It even has positioning holes and is made of PMMA. So I then do optic capture, having freed up the vitreous. It's very important to free up the vitreous so that you don't snag onto vitreous, and when you suture, you don't catch onto vitreous. I'm doing a paracentesis that helps me in the direction my needle needs to pass. I'm using an Alcon PC7 with a tenoproline here, and I use a passage that is created for the anterior chamber maintainer to slide in the needle. And only at this time do I let go of this lens. So with the lens forceps, I basically bring that lens out so that I can see exactly where the haptics are. Because with these tightly pigmented irises that are rather thick, it's difficult to see. But even here, you can see where the relief of the haptic is. Okay, so you do not miss when you pass the needle under the haptic. So this is the Sipser sliding knot that may seem very confusing initially. Okay, but what you're doing is you're bringing the suture onto one side and tying them. This is using the hook that I showed you earlier for retrieving the suture. And then you just do your 3-1-1 or 3-2-2 as you wish with this suture. So you take the loop and you put on your 2 or 3 throws, and then you pull the free end through, and then you tie by pulling the 2 ends that are free. So one is on this side and the other suture end remains here. So it's the same for this. So initially, I just put 1 throw each side. I don't tighten it. I make sure the lens optic is centered before I tighten it. And then I go on and finalize the suture. Now I'm going to pop this back through the pupil. The optic should be gently allowed to slide back and not push back, because you can actually slide the haptic off your sutures even if you've tied them tightly. So I use intraocular scissors that is made by MST to basically cut the sutures directly there. And then I like to always create a peripheral iridectomy there with the retractor. Just lower the cut rate to the minimum, vacuum of about 200 to 300, and then with the AC maintainer, maintain the anterior chamber, seal this incision, and then pull it out, the AC maintainer, when you've sealed the second incision. So let's look at more videos. You're going to see that this lens was not visible at the start of surgery, but it can be brought easily into view with the aid of indentation as well as iris hooks. So you grasp what is most anterior where there is no vitreous that would make it safe. Okay? So you can use instruments to grasp the haptic, which is probably the easiest. And then you hold on to the optic, which I'm using a lens holding forceps. Now it is very important to release the capsular bag, because you can see the contracture of the bag actually induce the capsular phimosis. And you can see this, this is a very old, again a PMMA lens with positioning hole, and these are proline haptics. You can see how bent they are. Alright, they don't have a good memory, and they're still bent even after physically removing this cocooning capsular bag with Somring's ring that has actually over the years caused this bending and overlapping of the haptic by the optic by the haptic. And you can see once I freed it all, I'm turning this lens over because it was really upside down. But you need to be sure that you have no vitreous in that space as you're doing the flip. Okay, so you need two instruments to do that, and you saw how I did it. Release the capsular bag completely. Make sure you don't have any vitreous there, because if you're going to place your sutures, you don't want to be catching on to vitreous behind the iris, because that passage is really a blind passage. Next, I'm still holding on. I don't let go of the optic. That's why it's very important to have all your instruments ready. When you start doing this, the nurse needs to have the retractor, everything all ready. Sutures mounted. Okay, I don't let go. I bring that optic up so I can see where the haptic is. Put in some myostat to constrict the pupil to the best of your ability. And once you have the passage of the two needles, which generally are parallel in direction, you then let go with your left hand of the optic. And then in this case, again, you then do the Seepster sliding knot with the aid of that suture retrieving hook. And then once you've tied it into place, you can do a mechanical like this, what I'm showing you here, which is just a paracentesis just next to the place where you're applying the knot, and you exteriorize the two sutures and tie your knot. But I generally prefer the Seepster sliding knot. More cases. So look at this other lens that is really dangling. But again, with indentation, you can see where it's dangling from. This is an area with no vitreous. There may be vitreous here. You want to avoid that area. Then once you grasp onto the most anterior part of the lens complex, you grasp haptic, grasp optic. Doesn't matter whichever, as long as you have a good grip and you're not holding to any vitreous, right? You can actually change the direction of this lens so that there's something that's convenient for you to subsequently fixate to the iris. You will now see the 21 and the 23 gauge lens holding forceps instruments in view soon. I'm holding on to this, right, and not letting go of the optic. It doesn't mark or scratch the optic, and it doesn't lose grip of the optic. It's really very good, especially if it is hydrophobic lens. You can see me clearing up the bag with Somring's ring. This can sometimes be a problem because it can drop if it's calcified if you're not careful and bring it to the anterior chamber. And it's really better to manually pull this out rather than use a retractor. So now you can see the two instruments, the 21 gauge on the left and the 23 gauge on the right. So I rotate that to position. Why? Because I'm more comfortable passing the sutures this way. And so I use this paracentesis, which is one for the infusion, to also allow the passage of the PC7 proline suture from Alcon. To basically, once I have them both generally in a parallel direction, I'm happy that they are well placed. They've caught the haptic behind. That's the only time you let go of the optic, and then that's the time you apply the Seepster sliding knot. In this case, you can see a mechanical suture there, and this is a Seepster sliding knot. Basically, the concept is simple. You exteriorize the portion of the suture here on the other side of where you've sutured the iris, and then you tie one to the other. So obviously you have to loop the intact portion, which is the loop of the suture, and then pull the free end of the suture through. You don't slide it through, but you basically release the optic in. If it's not very round, you can just tap at the iris there to round off the pupil. And then, as I said, I like to create a peripheral iridotomy with the vitractor. This is a 23 gauge posterior cutter, and this is very nicely and elegantly done PI. Okay, this just prevents a reverse pupil block that may actually cause the lens to settle in a deeper position than what we would like it to be. And if you did an OCT for some of these patients without a PI there, you may see actually a posterior bowing of the iris and the IOL really very posteriorly placed. So this is my routine now. Show you some more cases here. Very often we don't see the lens unless we start to jiggle the eye. So once you jiggle the eye, which is how I often start these surgeries, we know exactly where the lens is and where it's hinged. Okay, so sometimes you might have to rotate your microscope so that it's comfortable for you. And then once you grasp, you can either grasp the rhexis edge. Right, in this case, it was not so tightly bound to the optic, I could grasp it. Sometimes you grasp the haptic. Sometimes you have no choice, you have to grasp the optic. And then you want to free the bag, a very, very important concept. You want to release the haptics, and you also want to get rid of Summering's ring, which if you don't, and you're not careful, may subsequently drop to the back of the eye, and on another day, pop to the anterior chamber and contribute to corneal decompensation. So again, you'll see repeatedly just lifting up the lens with these forceps that show you the outline of where the haptic is passing behind. Lifting up the haptic also is important, that it helps you to avoid vitreous, catching the vitreous as you pass the needle behind in a blind fashion. Okay, and once you've done the passage there, you let go of the optic, and then you do the tying of the knots. That's a Sipser knot, which I generally prefer because it helps the knot to settle very snugly against the iris. And what you want to do is to get a nice round pupil that you see me repeatedly do, is to really have a very peripheral placement of the knot, which you can see here. Okay. Now, if you had an arcus snellis, it may be difficult to actually see where you're going to hook the suture. But with this particular hook that I've designed, actually because the edge is blunt, even if you went into the anterior chamber angle, you wouldn't cause hyphema. Okay, if you're not really too rough, it doesn't cause hyphema. And so I can do it under low magnification, and I can do it really without really visualizing where that suture is. It can be difficult because our irises can tend to be dark. So from iris fixation, I'm then going to move on to talk about glued lens. And I think there's been a lot of interest in glued lens. That is not my first preferred technique for lens fixation in most eyes, because generally it is far more invasive. We have to open up conjunctiva. These eyes are complicated already. Some may have had trauma and may have glaucoma. And I generally like to preserve conjunctiva in case they have need of a filtration surgery. So this is not my go-to technique. This is my fallback technique if the iris fixation fails. So I have two instruments that ASICO has helped me to design. Again, I have no financial interest. They are actually a micrograsper for the haptic, okay? And you can grasp the haptic depending on the situation, either horizontally or vertically. So what does this mean? So if you have a three-piece lens, if you're grasping it end-on, all right, this is what we call a vertical grasper. And if you're grasping it from the side, this way, for example, the trailing haptic that is used in the glued lens technique, basically you want to grasp it from the side. Okay, when you grasp it from the side, basically you use this other micrograsper, which we call horizontal, because of the way the groove is placed horizontally. So I just want to show you how I started doing this technique. All right, very important to mark where the center of your pupil is, where you want to center your IOL, because if you don't do this properly, after the lens goes into the position that you've created in the flaps, it's very hard to center the lens no matter what you do. You really have to change the transscleral position, all right, in order to center this lens. So this is taught to us by Amar Agarwal using the help of a glue. The technique was introduced by Gabor Scherer. And basically, these are trabeculectomy-like flaps, okay? And although Amar teaches us to do it 1 mm behind so that you have as much haptic to exteriorize as possible when we go very anteriorly, I generally like to do it about 1.5 mm behind to avoid chafing of the iris. If you get chafing of the iris in these cases that can cause hyphema and pigment dispersion, then basically what they have introduced is to do a peripheral iridectomy in the place where the haptic is coming out. Okay, so you saw one being externalized. Okay, I'm just transferring hand to hand to get view of the end of this the haptic. This patient had a previous iris fixation, so I was loosening it off. And this is the horizontal grasper. And so you see actually these tips are preserved and they're not crimped by the forceps. If you use tooth forceps and you're not very careful, you can actually crimp and kink these that are tips that are very, very important to keep straight as you do this transscleral passage. So you can use a 27 gauge or preferably a 26 gauge needle, which is passing in a half thickness scleral depth and perhaps a bit more anteriorly in order to get a greater length for greater stability of this lens. So after placing in an air bubble to basically get rid of all the fluid from the sclerostomy, once the bed is dry, we can then apply the glue. Okay, and the flaps can be actually attached onto the base, and then you can glue on the conjunctiva. Now let me show you a modification, which is the technique which I generally prefer today. So what I call is, this is the side flap. Okay, and this patient is aphakic. Very important again to mark exactly where the center is. And then when we have dissected the conch, you look at these flaps. They are not a conventional flap because the hinge is on the side, and you need to put the side that the haptic will pass under this intact flap. So you can see again, this patient has had vitrectomy done, so I don't really need to do any vitreous removal. It's been cleanly removed by the VR surgeon. Use the end grasper to hold on to the tip. Okay, and as you introduce the lens, this comes out, all right, and it is not crimped because it's been grasped properly. And then the other end is being passed. Okay, I'm holding it and it's presenting its side. So I use the side, the horizontal grasper, and this comes out without crimping. Okay, and then creating the passage in the partial scleral thickness, we can then easily thread this into the passage here in the 26 gauge thickness there, and you can see it goes in nicely, and then you can center that lens. So what's good about this side flap is that it basically covers this passage as the haptic traverses into the scleral tunnel, and when you put the flap back, even if your flap is not so well created and shrunk a little, you will never get an exposure of that haptic, nor would you get any wound leakage because of a foreign body just crossing that gap as you put the flap down that you would otherwise have with the traditional technique. So this is what I routinely do today using the side flaps, and I'll show you more cases here to illustrate the key points. So again, very important to have the center marked out to know exactly where. Okay, so 1.5 mm is the distance posterior to the surgical limbus I like to create. And in fact, today I make these flaps smaller and smaller, and you can see them, they're getting shorter and shorter. So they're really minimally invasive. That's a micro mini crescent. This is a 26 gauge needle going partial scleral thickness. Okay, so you can see I then create it on the other side. It doesn't matter which order you do them. Okay, but you can see these are really getting smaller. The flaps, they're narrower. You don't really need that much of a flap, just something to make sure that where your sclerostomy is and where your haptic is being exteriorized, it is going to get well covered with sclera. So these are the pair of instruments, one horizontal, one vertical. Inject, and when you inject, make sure that as the haptic is being presented, you grasp it with the vertical aligned groove in this forceps. As you continue to inject, you exteriorize this. Don't kink it, very important, don't kink it. Priya Narang has actually introduced a technique where you don't need assistant. You can see my assistant not so experienced and just yanking onto this. Okay, so what she does is she really pushes the optic to the other end. So the forces and the lie of the lens actually cause the vector forces to keep this within the sclerostomy. So you go in then, and you can see the horizontal grasping. So even if it's a very small pupil, you can still see this well enough. The tip is not kinked, and you just thread this into the scleral tunnel that has been created with a 26 gauge needle. One little trick for you is that you don't want the eye too soft when you thread this, because sometimes you can't find the track again. Okay, so I'm just checking to make sure that the lens is well centered, because this really has a small pupil here. This was a patient who had endophthalmitis, chronic endophthalmitis, and I had to remove the entire lens bag complex. Okay, and then we just glue it on, and then apply the excess glue for the conjunctiva. And really, the patient is really quite comfortable post-operatively, minimal anterior chamber cells and flare, and a lens that is really very, very stable. Certainly far more stable than if you did an iris fixation procedure. So this patient had a single-piece lens that my VR colleague picked up from the macula. And what we do together in this conjoined surgery is that he will start with the vitrectomy. All right, so he will pre-place his sclerostomy there for the infusion. And then once he's taken the lens from the macula forwards, he leaves it in the anterior chamber that's filled with some viscoelastic to protect the cornea. And then I will take over from there. And I'm jealous because he takes a shorter time than I do. All right, his vitrectomy is just under 30 minutes, but mine takes longer. All right, of course, if I do a lens fixation, I'll be out in about the same time. But if I do a glued lens, this will take definitely longer. And this is far more invasive than with the iris fixation. So you can see here, I'm just cutting the lens and using two forceps again. I just rotate it somewhere that's comfortable and safe for the eye. All right, creating that tunnel there. So you see repeatedly the same steps, and after a while, I'm sure if you've seen enough of these, you can go to YouTube and watch the surgery of other surgeons, and I'm sure you'll be able to handle these cases yourself. Right? You need an assistant here. I use generally AMO lens, it's an AR40E. This lens I honestly prefer to the MA60 because the edge, the anterior optic edge, is really not square, it's curved. And so if your lens is rather anteriorly placed and is actually positioned such that it chamfers the iris, it does not cause any bleeding, which I've seen actually in cases that have had a square edge lens where the edge is chafing against the iris that needed explantation. So again, very easy if your tunnel is wide enough. So I would advocate a 26 gauge. In fact, today I do see some surgeons just using a diamond blade with a step. It doesn't matter even if the tunnel were wider than what the haptic size is. It would be pretty stable because of the curvature and the pressure within the eye that actually locks that haptic into position. So this is the patient post-operatively. You can see it's very quiet eye. At 1 month, really you can hardly see anything of the flaps. Okay, so this is a patient who has had an anterior chamber lens, and he's got a very low cell count, and this lens is rather phacodonatic, and he's heading for corneal transplant if we don't do something. So as I said, you can see all these flaps getting smaller and shorter. All right, so I mark out exactly where I want the sclerostomy to be. You do it for the other side as well. So generally, I like to sit temporally, and I'm placing them at the 12 and 6 o'clock position. I don't have to think when I do this because I know that that is actually the shorter diameter and gives me the most haptic to exteriorize. Okay, so this is the AC lens that comes out through a 6 mm incision. Remove any viscoelastic from this patient who had severe trauma that caused traumatic mydriasis. Close up the incision so that it is watertight. Remove vitreous that is present here. Very important, even up. Sometimes you have to indent the eye or even rotate the eye to ensure you've had all the vitreous removed. And then you can see the lens going in and then being delivered externally. Okay? And then the same being done for the fellow side, opposite side. So I actually control the infusion. I don't have the infusion running continuously. If I want the eye soft, I lift my foot off. Depending on which stage of the surgery, like when I thread this in, I like it a bit firm so that it can find the passage that was created when I created the tunnel with the needle, and then I don't keep the infusion fully on because there's viscoelastic and so on that does help to maintain the anterior chamber. And now I'm just going to close up the pupil to reduce the glare that this patient is suffering from with this very, very large pupil. And this is just application of the Forceps sliding knot. Okay, so at the end of this, you will see that the patient has a small pupil. And with this pupil small, we can then put the air bubble in. Okay, very important for the air bubble so that it can be maintained there, and then we can dry up the incision, and then we can put on the glue effectively. So this is the patient post-operatively. Now I'll show you probably the last case now, and you will see that I've changed my position for this case, and I'm doing a 3 and 9 o'clock placement of the haptic. In this patient here who had a previous incision here. And again, I'm doing the side flaps. Okay, important to mark where the center is so that your lens is perfectly centered at the end of the case. This is a 26 gauge, creating the track for the glued lens. And this patient had a very sized lens, and again with corneal decompensation. And he didn't like his large pupil either. In fact, it's a she. She didn't like a large pupil. In fact, she had severe glaucoma after this road traffic accident injury to her eye. And then I was rather worried because she had a very limited field of vision left because of the advanced stage of the glaucoma. The cup was 0.9. But I elected to do what I felt was best for her lens and for her cornea in case she requires a kind of corneal procedure. Subsequently, I wanted a very stable lens. Pupil is really very large here from traumatic mydriasis. I wouldn't really want to use the very size lens or the artisan lens again, although I could easily flip that over and do attachment retropupillary position. But I felt that the best procedure was to give her a stable lens, and basically I subsequently closed up her pupil in a similar manner like what you saw in the case before this, in order to reduce her glare, and glare can be very disabling to these patients. So basically this patient, from a very sized lens, I changed it to a 3-piece lens which was sclerofixated, and you can see sometimes it's more comfortable for me to sit temporally than superiorly when I'm doing this pupilloplasty step. And you should be flexible. I normally ask for sterile scope handle so that I can move the microscope around. And sometimes if you can't see the lens well, you might even want to tilt your scope or move the scope to a position where it is easiest for you to view that lens, and also bring it to the anterior chamber. So sometimes you might have to move around to get the best view and the best leverage for that lens that is subluxated. So this patient again had a nice triangular pupil and a very, very stable lens outcome. Fortunately, I did not wipe her out, and she had a good vision. In fact, this patient had 6/9 vision immediately after surgery. And her cornea has stayed pristine to today, although it was less than 1,000 when I saw her. So in summary, I've actually shown you various techniques of IOL fixation, and I think it's very important to have appropriate instruments with you, because this makes surgery so much easier and safer. And also, really, I really still feel today that my go-to technique is still iris fixation. It is easy to do. It is within half an hour, even including vitrectomy, you'll be in and out of theatre. It is not invasive. You don't have to open up conjunctiva. Even if the haptics do dislocate, often they would dislocate only one at a time, and you would be able to redo this procedure if you felt that the first procedure had not been done properly. Now, generally, my principle is that if I've done a good surgery that I've been happy with, and the patient comes back and this has again dislocated, I would generally change my technique. And in fact, the very first case of the glued lens I showed you was a patient who had failed iris fixation. I fixed him twice, and again, he subluxated on one side. What I did was then to convert that to a glued lens technique. So it's very easy. The free end of that's not attached to the iris is the first one that you fix, and then I just released the haptic off the iris and then fixated the other point for a glued lens technique. I would also prefer to use this technique if I'm dealing with a post-vitrectomy eye, because there isn't that vitreous there to give the support for our iris-fixated lens, it tends to be very, very wobbly and would affect the quality of vision because of the movement of the lens. Sometimes I do use iris clip lens in a retropupillary position, always in a retropupillary position to avoid the cornea and its complications. In the case, for example, that is having a hazy cornea and you're collaborating with a corneal colleague to do the surgery, very often you can't see to place the sutures properly. You can't see whether you're hooking the sutures, whether your tying is appropriate. So I want the fixation to be really quick. And you know, when the cornea is very hazy, you can actually fix iris clip lens by feel. Okay, I just use the cyclodialysis spatula and coming along the same alignment as the iris clip lens, I can feel whether I've actually caught onto the clip. So it can practically be a blind procedure. So I do that generally for patients that are coming for a combined procedure with a corneal transplant, which often requires explantation of an anterior chamber lens anyway. So since I'm going to have such a large incision already created, I just put in an artisan lens. Okay? And I find that patients who are atopic, who are chronic eye rubbers, who have got floppy eyelid syndrome, who are always touching the eyes, even patients who are having obstructive sleep apnea, they're always having floppy lids and touching the eyes and so on. These patients, very often, even after you've fixated them, even with a glued lens, they tend to redislocate because the patients are using their knuckles and going at the eye when it's itchy and uncomfortable. Success using an iris clip lens because the overall length is much shorter. It's about 8.5 mm in overall length. So if you rub here, it's not attached to a solid structure, so the lens would presumably move away. And so there's less chance of dislocation. Whereas if you have fixated this to, for example, to the sclera, you rub, it will actually slip out of your scleral tunnel. So even though it's been glued in position, the glue is only temporary to help you to place the flaps on and the conjunctiva on. You don't need the glue to hold the lens in position really, because the glue disappears within a couple of days. So actually, what is very important is that if you have a shorter overall length rather than the 13 mm haptic to haptic length that you would have with a 3-piece lens, even if you use iris fixation, right? The shorter length of the haptic to haptic distance for a iris clip lens actually allows this movement within the eye that actually avoids its dislodgement. And as I said also, if I'm going to implant an IOL like an AC lens for a 6 mm incision, I generally just put in an iris clip lens, which I feel actually can stay much longer in the eye in people who are chronically rubbing their eyes, and also in eyes where you have poor view of what's happening because of the state of the cornea. Thank you. Are there any questions? Okay. So basically you are asking about a glued lens fixation. How do you avoid a tilt, a lens tilt? Okay, so we talk about sensation, and also there is a problem of a tilt. Now whether it's tilted or not depends on whether you are able to get the sclerotomy equally posterior to the surgical limbus. Okay, if one is more posterior, then you have a tilt. If they're equally posterior, then you have no tilt. So generally, studies have been published from Amar Agarwal's group actually have shown minimal tilt and minimal astig induced by all these glued lenses. So if the patient rubs the eye, basically the patient has got a 3-piece lens that is 13 mm haptic distance, and when you rub, basically this can only go so far because it's already near the ciliary body. Generally, I would do peripherally so I can dilate the pupil. Yeah, but I don't think it really makes that much difference where you place that, because what happens is it slips. Okay, you find that the knot is still there, but the haptic has slipped out. And you'll find that the knot can still be very tightly tied, but this, you know, a knuckle cannot compete with your knot with a 10O or a 9O Prolene. So it slips out because these are long. Yes. You don't have to remove it unless you're going to use a very similar site.
You wear a mask 3 piece, right? About the 1 piece. You can get it.
You can use a 1-piece PMMA, but not a single-piece hydrophobic acrylic, nor a plate haptic. You can't use these for fixation.
Yes, it's possible. They don't use 3 piece.
Yes, you have to use a 3-piece like what I showed you, or a single-piece PMMA is also possible. But far more difficult and challenging, because if you are on the learning curve, you can break it. Yeah, I've done it. So in fact, my first case was a PMMA one, and I broke the tip. So my fellow looked at me, I said, let's break the other tip. But just the little end, so I was fine. What kind of blade? Crescent is a mini crescent. I think it's quite generic. It's a standard crescent, but it's smaller in size. Yes. I mean, if you look at Ahmad Gawal's surgery, it's big. I'm small, so I like small instruments. Any further questions I can help you with? Clarify anything? Yes?
Do you put the haptic in this pocket? How far do you put it?
Okay, I think this is a very important question. You know, we would like to put it as far in as possible, okay? But if you put it very far in, right, and if your eye is not the right pressure at that time, post-op you have a horrendous astigmatism, okay? Because you've done this to your eye. Because you push this in, it will go in, and it will squeeze your eye into this shape, okay? So what I always do is when I put this in, I make sure the eye pressure is correct. It's not a soft state. Because if not, you just keep pushing in and you're very happy. And tomorrow a patient very unhappy. 10 diopters of cylinder. Okay, so have a good pressure in the eye and then put it in until you feel it's reasonable. You don't really want to move the lens anymore. Okay, and it's in a good plane. Yeah. So it needs to be in a position that's not too deep. That means you've not pulled enough. Okay, but if you pull and the eye pressure is firm already and you find that, oh, it's not really going. If you pull here, it's pulling the lens and this haptic, then you don't advance it any further. So if you want to know exactly, then you could actually have a PMMA, you could actually have a 3-piece lens and have a look at it before you implant it. For this particular eye, roughly, if I put it over the eye, how much I will be able to exteriorize. If not, thank you and good luck. Thank you.